I'm Dr. Edward Mikol. I'm one of the founding partners here at Carolina Orthopedics. I did my training at George Washington University in Washington, D.C. That was college, med school, and residency. And then I went on and did a fellowship in sports medicine and arthroscopic surgery in Nashville, Tennessee. I came to this area in about 2000, and I was working up in Myrtle Beach with a group that no longer is in existence. Dr. Bohan and I opened up this group in 2004, and we've grown now to 6 orthopedists plus 2 other docs, and built this building, and we're trying to reach out and educate the community as best we can, so I appreciate everybody coming tonight. What I'd like to do is, there's a lot of topics here in sports, in shoulder and sports injuries. It's going to be difficult to cover them all in depth. I'm going to try to sort of gloss over a few of the things in the beginning, and if you can bear with me through the presentation, we could go back on anything and answer any questions later, but it's kind of hard in this limited amount of time to go too deep into any one particular issue. So we'll jump right into it. Common causes of shoulder pain. Rotator cuff tears are probably the #1 thing, particularly in the population we have down here. But you can get other conditions of the shoulder, arthritic conditions, just like you can in the hip and the knee. Shoulders can pop out of joint, so-called dislocations or instability. And there's a condition called adhesive capsulitis that people refer to as a frozen shoulder that we'll go into briefly as well. So the #1 thing, let's go over the anatomy here. The shoulder is made up of basically 3 bones in particular. The humerus is the arm bone. The shoulder blade, which includes the acromion and the scapula, as you see here, but also the collarbone comes in there. As you go over to this other picture here, the rotator cuff comes out. It's a muscle, becomes a tendon around here, and then attaches to the bone. And if you're getting tears, they usually occur in this area. So when you look here, there's a space above the rotator cuff, right here. That's what we call the subacromial space. And then there's the joint space down in here. And those are 2 different areas, despite being quite close together, and different conditions affect each of those areas. The rotator cuff functions to sort of center and keep the ball and socket in position, and also to rotate, literally, the arm, whether it's rotating it out this way or rotating it up and out. It rotates the shoulder, hence the name rotator cuff. This long one on the outside here is signifying what the deltoid muscle would do, and that comes into play when you have rotator cuff tears that we could talk about a little bit later. So what are the symptoms? More often than not, rotator cuff symptoms are in this area from the shoulder down to here, and it radiates down your arm a little bit, but usually not below the elbow, and people are generally confused as to why it's down here, and we may put a shot up here. Well, the rotator cuff's up here, but you may feel the problems down here. You can have pain at rest, pain at night when you're sleeping, pain with lifting and with use. A lot of people don't have symptoms of the rotator cuff, and they're surprised when I tell them they have a tear, because they'll say, it hasn't hurt me ever before, and you look at the MRI and I'll say, well, the rotator cuff tear has been there for years. So you can have pretty good function with the rotator cuff being torn. Guarding is resistance to movement of your shoulder. So if I try to move it and you're kind of tightening it up because you know it's going to hurt, that's what you'd call guarding. You can have pain with motion. You could have a crunching, popping, almost like a Rice Krispie sound when you move it. That's called crepitus, and that can be related to a rotator cuff injury. Weakness, and of course, what I'm showing you here is what they call an impingement sign. It's one of them where you kind of rotate the arm and you're trying to create what we call an impingement. The impingement is shown here where the bone above, the acromion, is sort of pinching the rotator cuff and the bursa. So the rotator cuff comes in over here, and we have the bursa above it. And both of those can get inflamed, and the rotator cuff can be torn, but we're putting it into a position that irritates it. And you will do that on your own when you reach up and you try to put something into the cabinet and you notice that it hurts. So the spectrum of rotator cuff injury could be a bursitis, which technically isn't a rotator cuff problem, but it's right around it. The rotator cuff can be inflamed and irritated, what you're seeing over here. And then there can be a tear in the rotator cuff. That could be a full thickness tear or a partial tear. And now we'll usually get x-rays. Sometimes the x-rays are completely normal, even if you have a rotator cuff tear. but a lot of times you can get a little bit of an irregularity where the rotator cuff attaches here. That's what they call the greater tuberosity. And if you have a big enough rotator cuff tear, your shoulder starts to migrate towards your head superior. So you get what we call a decrease in the acromiohumeral interval in there. So we also look for bone spurs. A lot of people will ask, why do I need x-rays when it doesn't show the rotator cuff? Well, this does not show the soft tissues, but it can show some things that can contribute to the problem, such as the bone spur that you see over here. You don't see it on this one, but it sticks down, and when you lift your arm, that can pinch your rotator cuff and cause problems. And some of you I know who have had surgery with me, we've discussed that, and we've had to resect the bone spur. Other conditions, and we'll get into this, is osteoarthritis. Right over here, the joint space is narrowed between the ball and socket. And just like you get arthritis in a hip and a knee, which are far more frequent than the shoulder, you can get it in the shoulder. Now, when the rotator cuff has been torn for a long time, you'll get a degeneration of the shoulder. The shoulder's been moving abnormally for so many years, it starts to degrade the shoulder, and you get what we call rotator cuff tear arthropathy. Because your rotator cuff's not there to hold your shoulder sort of in place and have it function normally, you get irregular motions, and that's what's causing your problem down the road when you get this degenerated. Now, this is a difficult problem, but we also have solutions for that. We may order an MRI, and this would be a normal MRI here. You see the muscle, and then this part that turns black here would be the tendon. That's the rotator cuff tendon, in particular the supraspinatus. Now, if you look over here, you can see that it's attached to the bone, and the bone looks bright, the muscles look moderately dark, but the tendon is supposed to look a dark black. When there's a problem with your rotator cuff, like you see here, there's a bright, what we call signal in the tendon. It shows it bright, which means it's inflamed. This one is not torn, but it's inflamed. Now, when you go to the one over here, you can see this black tendon does not attach. That's a rotator cuff tear, a relatively small one. What you're seeing over here is a small one on the left with a very large one on the right. This tendon goes all the way back to here, to almost to what we call the glenoid. That tendon is not able to be repaired. So if you have a tear that progresses and it gets too bad, you end up with a picture that looks like this, and you'll end up eventually with a shoulder that looks like this one on the far right. So we like to get it before it gets to that point. So what are the treatments for this? Well, non-operative treatment, which is the majority of patients. These are for tendonitis, bursitis, some rotator cuff tears. You'll hear me tell you, if you do have a tear, probably we want to fix it before it gets to be too large and becomes an irreparable tear. But a lot of people with irreparable tears are non-operative candidates. You may be able to get by without a good rotator cuff. It depends on what you do and what your activities are day to day. Now, if you fail conservative care, that's when we operate on these. Now, it could be a repair of the rotator cuff, but it could be a replacement of the shoulder, which I'll show you in just a few minutes here. So how do you treat it non-operatively? You get rid of the things that are bothering it. And if you can get by in your life without doing something that irritates it, if you swim a lot and that irritates your shoulder and you're okay not swimming, you might find that you do okay without having surgery or further treatment. Anti-inflammatory medicines, Motrin, ibuprofen, Aleve, Advil, Celebrex, all that stuff. Home exercise programs are very important, as is physical therapy. If you can get the rotator cuff muscles functioning correctly, you can decrease your pain significantly. And even if you have a tear, if you can get the remainder of the rotator cuff functioning well, then you can get yourself out of pain and have good function, and that's, of course, what everybody wants. Injections are another option, and all of these things we generally try. The exercise program is to stretch the joint, because a lot of people get tight, and when the shoulder is tight, it affects how the shoulder rotates inside the joint, and that can cause your shoulder to rise superiorly and pinch the rotator cuff. So one of the things is to loosen up the joint by stretches, also strengthening the rotator cuff. This muscle here is the supraspinatus, and you want that muscle pulling the shoulder to the right here, because the deltoid muscle, the other muscle, is trying to pull your rotator cuff up. So if it rises up like this and then rotates, you're going to pinch up here. If it rotates underneath it without rising up, then you might not pinch. So it's very important to do the exercises and including physical therapy. We have 2 therapists here who are quite adept at getting you back in shape and getting you functioning well. So when that does not happen, what do we do? Well, arthroscopic surgery is the #1 way to treat this. And if there's a tear that can be repaired, in my hands anyway, arthroscopic surgery is the way to go. In the past, we've done open procedures, but arthroscopic surgery now has advanced to the point where if we can get a tear repaired, we can do it arthroscopically. So that means small little holes, usually 3, 1 in the front, 1 in the back, and 1 off the side, similar to what you see here. And we can minimize the damage to the other muscles, minimize the scarring. It's more cosmetic, but we put a video camera in there, and by going through the video camera and using various instruments, we can repair your rotator cuff. And so this is an example here, not the best drawing, I guess, but of taking a bone spur off the acromion with a burr. It basically grinds that bone out, and we could do that through the little incisions. We take these spurs off here, and if you look at this one's straight, this one has a little bit of a curve, this one has a big curve. Well, sometimes you have to remove these bone spurs in here. Some people don't have them, some do. You don't have to have that to have a rotator cuff tear, and you don't have to have a rotator cuff tear to have that. So we treat what we need to treat in there. Where the collarbone meets the shoulder blade right in here is called the acromioclavicular joint, and a lot of times I will do a distal clavicle excision. You can have some pain from that bone in there. That joint can become arthritic and cause pain just like any other arthritic joint. So this is just briefly, historically, is to the far left, big open rotate. Some people do them that way, and for years, and it works, and it's fine. But you know, far right is what I do. In between, there was something that used to be a mini open, where we do everything arthroscopically, but make a small incision to repair the rotator cuff. To me, that's kind of a little bit archaic at this point because we've developed past that. So what do we do arthroscopically when we repair it? Well, we grind down the bone here with this burr, and we make the bone bleed, because the healing comes from the bleeding bone. Has a lot of, you hear the term stem cells and all that. Well, there's a lot of potential to heal from those. We make little holes in the bone to the upper left here, and then we insert these bony anchors that are in the middle. These are one metal, one is an absorbable plastic, but there's all sorts of different materials. We drill the hole in the bone, we put them into the bone, and with the sutures we pull the rotator cuff down and repair it. And this is probably a little bit of an older version of what we do, but basic same thing. So now here we are looking in the shoulder. These are actual arthroscopic pictures. This rotator cuff comes down and attaches to the bone, and you don't see a hole here. This one does not. This is from underneath. This is a supraspinatus tear. As we go further, here's a partial tear. You can tell this is not normal, but it's not completely off. And generally, if these things are 50% or more torn, we usually repair them. As they start getting into what we call a high-grade partial tear like this one is, we would want to create that into a regular rotator cuff tear and repair it, or we can repair through the tendon. But again, contrast that with the full thickness tear that's on the right. So here we go from below. We're looking, here's the ball of your humerus where the ball and socket is, and we're looking up at the tear. The rotator cuff tear is the ceiling. Well, now we're on the other side in the so-called subacromial space, and we're looking down on the rotator cuff where there's a tear here, and that rotator cuff should come all the way down to this bone, and that's what it would be after the repair. So here's before and after. This is an arthroscopic knot technique where we tie. This is not exactly what we do. We have better anchors where we don't have to tie these knots, which means we can move faster, but it's basically the same idea. When you first go in between the bone above, the acromion, and the rotator cuff below, you get a lot of bursitis in there, and you can see this is sort of red, inflamed tissue, and that can be the source of people's pain and only the source of their pain. Some people, we go in and we just clean that up and don't have to touch the rotator cuff. So here's an example of after that. Below is the rotator cuff, above is the bone, and all that garbage, I'll call it, is taken out. Well, if we can get rid of that and that's not being pinched, your pain goes away. Here's a bone spur being taken off in the front, to the right. This is where it's ground away. So where there was very little space between here and here, now you've got a good amount of space there, and that decreases the rubbing that will occur. on the rotator cuff, and hence your pain. To the left here is the AC joint, acromioclavicular joint, where the distal clavicle comes in. And in here is where it's been ground away. Here's where the clavicle now ends, and this is what we call the acromion here. So that space is opened up. Well, in here, if this is arthritic and it rubs every time you move your shoulder, you're going to have pain. So after the surgery, what do we do? You get a sling. If you don't have to have a repair of the rotator cuff, you get a sling. And you can come out of that anytime, and we send you off to therapy, and you start working it right away. They work on strengthening, first getting your motion, getting the inflammation down in the acute stages, then strengthening, and finally, releasing you when you're back to a pretty good function. Well, if we repair the rotator cuff, we have to protect that. So for a while, we're going to have to keep you relatively immobile or avoid the stresses across that tendon. If you pull on it too much, you can rip out the repair. And depending on the strength of the repair will help us decide how early we could start you off on physical therapy. Some are very tenuous and you don't have a really good rotator cuff. It's kind of weak and sutures want to pull through it. Other people have, it's like a piece of leather. You can pull it down, put it in place, and it's not going anywhere. Recovery can take quite a long time. We say 6 months or more. Everyone goes at a different pace. They have different pain tolerances. Some get stiffer than others. Some will let the therapist move faster than others. Some tears are bigger than others. The big ones we have to go a little bit more slowly than the ones that are smaller. And if you've had a tear for many years, your muscles are pretty atrophied and it's going to take you a lot longer to recover than the next person who may not be that way. So you can't always just look at the next person beside you in therapy and wonder why they're going faster and you're not. So we'll get back to rotator cuffs if you have questions, but I'll move on a little bit to shoulder joint arthritis. There's many forms of arthritis. Osteoarthritis is the most common, but rheumatoid arthritis and inflammatory arthritis and infectious arthritis, all of it results in a loss of the cartilage in the joint space. And you could see we have a bone spur down here. This is not a normal ball, a nice rounded ball. You want to see that perfectly hemispherical or close to it. There's cysts underneath the bone right here. The joint space is narrowed so the bones are rubbing against each other. And again, that'll be the same on a hip, a knee, or any other arthritic joint when it gets bad enough. Similar in a way, the symptoms, you're going to have pain and limited motion. You may feel a grinding or a catching in the shoulder, just like a hip and a knee. Stiffness and weakness are common. Reluctance to move it, you're going to have pain when you move it. And it's up to us to distinguish, is your pain coming from arthritis, rotator cuff, or is it coming from both? And the goals of this treatment is, again, to get you back your life. You want mobility, usefulness, function. You want to be able to do the daily things you do in life, and that's my job. So non-medical treatments for arthritis, medications, anti-inflammatories can get rid of some of the pain and discomfort. Aspirin is an anti-inflammatory. You can reduce pain, swelling, inflammation, but other ones such as ibuprofen, Motrin, Mobic, Celebrex, there's a bunch of them out there. They all work, and a lot of you will have tried that before you even actually come and see us because they're readily available over the counter. Now, if you are unfortunate enough to have something like rheumatoid arthritis, well, that's different. It's a completely different disease process that can result in the same problem, i.e. a worn out shoulder joint. There are some other treatments for that the rheumatologist generally would do, such as Remicade or methotrexate. There's things like that they use. Glucocorticoids or corticosteroids we use in arthritis as well as bursitis or tendinitis. There's an inflammation. They decrease the inflammation, and that's the goal. And these other things here are mostly for the rheumatoid arthritis doctors to use. We don't generally do those as an orthopedist. And if you're reaching us, it means you probably have failed that with a rheumatoid doctor and you're coming to us. So cortisone injections are powerful anti-inflammatories, and I do a lot of those. Most people who come to me the first time with a shoulder problem will get one, probably 3/4 of the people. And when they work, we keep going. When they stop working, we have to find another route to get you better. PRP injections, while not approved necessarily and still being studied, we don't have great results papers that tell us this absolutely works, this does not work. But there's some evidence that it can be injectable into joints that are arthritic. People have studied the knees, and we do show a benefit there. The bad part about the PRP, really the only bad part, is that none of the insurance companies at this point pay for it. So that's more of a cash outlay for somebody who does not want to undergo surgery but wants to try something else. So we do try to do that and try to supply many options in treatment. Activity modifications, assistive devices, stretching, strengthening programs, physical therapy, just like with the rotator cuff, we try that again. Arthritic conditions of the shoulder can be treated surgically. Arthroscopy would be done more in a younger person who does not have a joint that's destroyed, and we try to clean up some things and maybe afford you some relief, buy you some time with your own shoulder before maybe down the road you need something done. But usually, if it's bad enough and we're doing surgery, it's going to be a shoulder replacement, either a whole shoulder where we replace the ball and socket, or a half of a shoulder, and sometimes in younger people we'll do, or what we call a reverse shoulder replacement for the arthritic conditions that I showed you earlier. When the rotator cuff is gone and it destroys your shoulder, the standard shoulder replacement doesn't work for that. So up above is the standard shoulder replacement. There's a metal ball attached to a stem that goes down into your humerus, and there's a socket, which you may or may not be able to see so well, glued into there. That's a plastic socket. Same thing we do on a hip, same thing we do in knees. Down below is the one that you can see. It's called a reverse shoulder replacement. Substitutes for the lack of a rotator cuff and replaces the shoulder joint for somebody who has both of those problems. And you can see the socket is on the ball side and the ball is on the socket side. And I don't know if we need to get too much into why that is, and I'm happy to answer questions about that, but it has to do with lack of a rotator cuff function. So when is shoulder replacement right? When you're having a lot of pain and the other treatment isn't working. That's essentially it. You can choose to live with it, and we could try all these options to get you better, but if your quality of life is not what you want it to be and you need surgery, then that's the time to do it. Medicines aren't working, shots aren't working. We can only do shots, maybe 2 to 3 times a year. We can't do them every month. You run the risk of infections, and if they're getting done that frequently, it means they're not really working very well. So here's, again, the components. This socket here gets cemented into your humerus usually. The ball sits on the surface of the bone with the rest of this stem going into the bone. And it mimics, your ball and socket that you have in there now. Here's a shoulder that is migrated proximally up superior toward the acromion because there's no rotator cuff. That is the shoulder that we do this reverse in. And the potential benefits, of course, you want pain relief and you want function, hopefully better strength to get back to doing the things you like to do. I'll briefly go into dislocations of the shoulder. Well, dislocations of the shoulder is when the ball pops out of the socket. That is usually a traumatic event, and it can result in a fracture in the back of the ball, and it's not so common in an older population to get these, but they do occur, and frequently when they do occur, it can be in combination with a rotator cuff tear, and often a large tear. So when people who are over, let's say 40, dislocate, we want to get MRIs to make sure there's not a large rotator cuff tear. It doesn't always mean you need surgery, but sometimes you do. The vast majority of dislocators we treat without surgery. They go to therapy and resume normal lifestyle eventually. In younger people, sports and athletes will see tears in the labrum there. And if those ligaments are torn and younger people are requiring surgery, that's what we repair. In an older population, that's not the typical mechanism or what we do. So if you came to the emergency room or to the office for that matter, we could try it, but it's tough in the office, you would do a closed reduction, non-surgical, sometimes with anesthesia, sometimes without. I myself had my shoulder dislocated, I had my friend pop it in. So you don't have to have anesthesia, but if it's been out a while and it's tight and the muscles are spasmed, you're going to require anesthesia for that. Frequently when we see them, they'll be in the emergency room and they'll be sent out, and then we see them in follow-up after that. Occasionally you need an open reduction. I've had people who come in who, believe it or not, their shoulder has been out for weeks or months even, and that's a much more difficult problem to treat, but chronic dislocators will require surgical treatment. Recurrent dislocators are going to be somebody who, if you lift your arm up and it keeps popping out on you or pops out easily, you could be sleeping, it can pop out, you will probably need surgery for that unless it settles down and scars in place. And that can be an arthroscopic versus an open procedure depending on age and the pathology we're talking about. One last condition I'll talk about relatively briefly is adhesive capsulitis, so-called frozen shoulder, people like to call it. We don't know why this occurs. It usually has a slow, gradual onset, sometimes after an injury, but sometimes not. It can just start up and people come in and say, I can't lift my arm to here, I can't get my arm behind my back or get the bra strap, taken care of. It's just, we don't know why it occurs, but there's a lot of limited motion. You're unable to reach and do the things that you want to do. Well, here the joint lining is inflamed. If you can recall some of those other pictures, all the red stuff in there is a very inflamed synovium, we call it, the joint lining. And that's what causes you your pain. We have to get that inflammation out of there, and they have, the people like to call it a freezing, a frozen, and a thawing stage. So when it's freezing, you're getting stiff. When it's frozen, you are stiff, and we're working on getting it unstiff. But the thawing stage is when it's starting to loosen up and you're getting your function back and getting your lifestyle back. You can try an injection in there to limit this inflammation. We can try anti-inflammatories and physical therapy. I'll keep plugging them a little bit. Physical therapy is very, very important in this process. It's very hard for you to push yourself quick enough or far enough to recover from this. Your pain is, you just need somebody to give you a little bit extra push there. Manipulation under anesthesia can be done where we put you to sleep if you're not making progress in therapy and make the shoulder move. You end up tearing some of the ligaments a little bit, and it still doesn't mean you snap your finger and all of a sudden this condition's gone. This thing takes a long time to go away, and they'll tell you, you got to have a lot of patience. You may make 5 degrees every time I see you, or 5 to 10 or 15, So it can take a long time to get back to normal. It can be recurrent, but usually isn't. It's recurrent in this is if I were to take you to surgery, you might need another surgery before you heal fully, because sometimes it gets stiff again. But once you get through the condition, it usually doesn't recur on you. And it can involve both shoulders. And I think I'll leave it at that. I don't want to overwhelm you with too much stuff, but well, thank you for coming. Appreciate it.